My name is Stefan and I'm a consultant anaesthetist with a special interest in oxygen toxicity. I'm also a dive medical officer, which means I have a huge interest in hyperbaric medicine and scuba diving. I was asked if I can give a talk about oxygen and the influence on the lung during scuba diving, and this is what this talk is about. To better understand the effects of oxygen on the body, I would like to give you a background on where we use oxygen in medicine and what are the pros and cons. After that, we will talk about the influence of pressure on the lung and then the influence of oxygen on the lung during scuba diving. So, let's dive in. Oxygen is one of the most frequent used drugs in medicine. It is used whenever we have patients suffering from lack of oxygen, which we call hypoxia. You might hear about hypoxia in patients suffering from cardiopulmonary diseases such as COPD, asthma, or even for heart failure. But you also might experience hypoxia in a more natural environment, for example when you go hiking or flying in an airliner. Whenever we do that, we are exposed to low pressures and we are exposed to low oxygen levels that might cause side effects like confusion, drowsiness, headache, nausea, or myocardial depression. In very severe cases, you get arrhythmias, bradycardia, so basically a low heart rate, or you can even have death. Therefore, it is vital for us to avoid hypoxia in our patients in medicine. And regularly, oxygen is used to do that. But the question is it always good? And I would like to show you a couple of studies about that. This is a study I've done a long while ago with Martin Zaremba. In this study, we examined the influence of oxygen on the lung function after general anesthesia and the postoperative recovery. What we've done is we selected 150 patients, divided them into two groups, a high oxygen group and a low oxygen group. The high oxygen group received 80% of oxygen during the surgery, and the low oxygen group received 40% of oxygen during the surgery. What you can see on the left side is that after surgery in the high oxygen group there was a reduction by 50% in the vital capacity from the baseline. In the low oxygen group we had a reduction of just 30%. Even the day after there was still a reduction by 20% in the high oxygen group, while the low oxygen group was nearly back to baseline. This already shows you that oxygen has a huge effect on the lung and actually lasts for more than 1 day. We could see these effects on all parameters in the lung function test. Back in 1954, now 70 years ago, one of the first papers about oxygen toxicity was published. It showed that oxygen has a couple of effects on your cardiovascular system. On one hand, it causes a vasoconstriction, which leads to a higher afterload, a higher resistance your heart has to pump against. But also it reduces the contractility and your stroke volume of your heart, which means the heart actually has less power to work against a higher pressure. And that already shows us that there is something wrong with oxygen if we give too much. In 2010, the European Resuscitation Council came up with new guidelines when it came to myocardial infarct. When I studied medicine and when I was in med school, I was told I can give oxygen to everybody. It doesn't matter, especially for heart patients when they're suffering a heart attack. In 2010, that actually changed. The first guideline came out that considered oxygen not to be beneficial in patients who don't really need it. So if a patient has normal oxygen level in their bloodstream, doesn't suffer from any pulmonary side effects, we actually started not to give oxygen if they really don't need it. And this was one of the changes we had. There was no real idea about what happens and why this is the way it is, but the numbers all showed that oxygen at a certain level might be not beneficial for patients. This is one of the very interesting studies when it comes to oxygen and myocardial infarct. What this group did is they had an oxygen arm and a no oxygen arm. So basically half of their patient received room air and half of the patient with a myocardial infarct received oxygen. And what they measured were three different things, and we come to that step by step. They measured the troponin level. Troponin is an enzyme that can just be found in the myocytes, in the myocardial cells. Whenever myocardial cells are dying, for example during a myocardial infarct, it gets released in the bloodstream, can be detected. So troponin tells us that there are, first of all, cells that are dying, and it tells us how many cells are already dead. In the air group, we had troponin levels of 2000 compared to the oxygen group where the troponin level was a little bit higher. That already tells us that in the oxygen group there were more cells that died from the oxygen. Creatine kinase is a similar enzyme that also can tell us about muscle death. And same here, the median level in the air group was less than it was in the oxygen group. But the interesting thing about this study was not just that. They asked the patients to come back 6 months later and did a cardiac MRI to really determine how much muscle really died. And here's the interesting fact. In the air group, the muscle that really was lost is around 13 gram, while in the oxygen group it was 20 gram, which is 50% more muscle loss. This led to a couple of changes. In 2017, the European Society for Cardiology actually became more rigorous when it came to giving oxygen yes or no. Till that, we allowed patients to have saturation levels of 95% and would then just consider to give oxygen. But after the AVOID study and the detox study, the cardiologist actually decided that we tolerate levels down to 90% of oxygenation in our bloodstream without giving oxygen if the patient doesn't have any side effects. And that was a huge change. Another very interesting study looked into mortality and survival after cardiac arrest. It's a very interesting study because it was very simple designed. Patients who had a cardiac arrest and then had a return of spontaneous circulation, which we call ROSC, were admitted to the hospital. On arrival in the hospital, this study group took a blood sample and just had a look at how much oxygen they had in their bloodstream and then compared it to the outcome. They created 3 different groups. The normoxia group, and for those of you who don't have any idea about the numbers, that is a very high number. The normal levels we expect in human beings is between 60 and 120. So 300 is already very much. And there's the ultra-high group, which is more than 300 millimeters mercury, but there's also the group with a lack of oxygen, less than we would normally have in our system. And what they could show is that the normoxia group, so the normal oxygenation group, had a better survival than the hypoxia group. They, after that, did a subgroup analysis and were able to show even more impact. Here you can see the oxygen level going up also means having a higher mortality, while the survival rate went down. So the ideal, best oxygen level to survive was actually around normal levels. In 2010, we also changed the guidelines for cardiac arrest based on that. So we nowadays just want to make sure we have normal oxygen levels. We want to avoid hyperoxia. We want to avoid a very high oxygen level because we know it's causing side effects. It's causing cell death, it's causing apoptosis, and it's causing more mortality when it comes to cardiac arrest, for example. The mechanisms behind that are not yet fully understood. We did a study a couple of years ago where we looked into protein changes in animals. What we did is we gave animals 3 hours of 100% oxygen and then looked in what kind of protein changes we could find after the 3 hours. The concerning point was not that we had protein changes that led to cell death and all these things. I mean, we are aware of that from the previous study we already had. The very, very interesting and concerning fact about this study was that we could see these effects even 7 days, a week later after the administration of oxygen. And that is really something concerning. We've already seen it for the lung function, then it lasts up to 2 days after having a high amount of oxygen, but we also see it in the organs that a high administration of oxygen can lead to organ changes, well, protein changes in the organs up to 7 days after administration. So what about the lung and pressure? This is a study that has been done in Germany by a study group. And what they did is they had a look in lung function in children when they went scuba diving to 1 meter and 8 meters. Well, yes, you can say it wasn't done in children, but I'm pretty sure the results are nearly the same when it comes to adults. So what we looked for was the MEF 50. Just to explain that a very little bit at this point. MEF stands for maximum expiratory flow at 50% or 75% of the vital capacity. It tells you how narrow your small airways on the bronchial level are. And the lower the number is, the more narrowing you get and the less flow you get. And if you look at these MEF 50-25 levels, when the kids went scuba diving pre and after scuba diving, you can see a reduction up to 10% of lung function in these kids. Another study done in this area looked at what a warm and cold environment is doing for the lung. And we could see similar results here. The cold environment actually led to more bronchoconstriction, more narrowing of the airways. And then the same study showed differences if you go scuba diving for 10 meters or for 50 meters. The deeper you go, the more effect of bronchoconstriction and loss in lung function you have. So this is what pressure is doing to the lung. But the original idea of this talk was to give you an understanding of what oxygen is doing to your lung during scuba diving. Based on the studies I already showed you, and based on the research I've done, I was intrigued to see what oxygen can do to my lung when I'm scuba diving. For that, I've done my own study. I went for a 40-meter dive, used a 70% bailout gas when I came back up, and I measured my lung function before and afterwards. And what you can see down here is that the oxygen actually has a huge effect on my lung function. So for my small and medium airways, I lost between 15 to 30% of function. You can now say, yes, that's a single person study, it's a non-blinded, non-randomized, not following any research guidelines, and you're totally right. But I tell you what, there are studies that actually looked into that. So here we are. This is a study that looked into the lung function of divers going with either air or with nitrox. And what you can see here is when you look again at the MEF 50, for example, the lung function before scuba diving had 5.9 liters per second flow in the medium airways. When they went scuba diving with air, it went down to 5.4, and when they added oxygen and nitrox, it went down to 5.1. And this happened at the same time also in the small airways, where the initial flow was 2.7, then came down to 2.2, and then 2.1 in the oxygen group. And the similar numbers for the bigger bronchs, 9.1, 9.1, similar, but then when oxygen was added, it went down to 8.5. This is another study that looked into exposure. So here they calculated something which we call units of pulmonary dose. In some papers you might hear about oxygen toxicity unit, OTUs. What it is, it's the sum of oxygen per minute. So everything above 50% is considered to be toxic in this study. This is based on a previous paper, and I'm not going into detail here. And what we measure is every percent above 50 per minute and calculate or sum that up over the time of exposure. So for example, if you dive with 70% of oxygen, this is 20% above 50. If you do that for 3 minutes, 3 times 20, your oxygen toxicity unit would be 60. And what they could show here is that the higher the oxygen toxicity unit was, the higher the UPTD was, the more loss in vital capacity occurred in scuba divers. So that tells us that oxygen actually has a negative effect on lung function when we go scuba diving. I want to summarize that and give you an idea where I stand when it comes to oxygen and scuba diving. In medicine, I still see oxygen as a drug, something we use, something which has side effects, and we always have to think about the side effects and if the benefit is outweighing them. And you technically have to do the same when you go scuba diving. Consider using higher amount of oxygen. When you go scuba diving and you do technical diving and you have a very deep dive, your nitrogen intake is high, and you want to make it a more safe dive, then the benefit of oxygen is actually outweighing the risk of oxygen. But you have to keep in mind your lung function might be reduced. But if you go for recreational dive, let's say 20 meters, and you dive nitrox, the question is the benefit of a 5-minute more bottom time outweighing the risks of lung problems it can cause? And this is something you have to decide for yourself. For every patient, for every drug we do in we give in medicine, we will do that. And it's the same thing you should do for scuba diving. I agree that a 20% reduction might not be anything that might be affecting you, but there might be scuba divers, especially with pre-existing lung diseases like COPD or asthma, where 20% is actually a reduction that might be significant. And here you need to consider the effects oxygen has and think about if the benefits are outweighing the risks. And this is something just you can do for your scuba dive, wherever you go and whatever your dive profile is. I hope this answers a couple of questions you have, and if there's anything further you would like to know, just drop me a line.